Is up. Been looking forward to you all day, Dr. Jackson. Thank you for coming.
Thank you, sir. Thank you, ladies and gentlemen. My name's Robert E. Jackson, MD. I'm a family practice physician in the upstate. I've been practicing family medicine for 42 and a half years. It's been my responsibility for the last 2 years to take care of patients with post-vaccine injury and COVID long haul. I estimate that I've taken care of between 400 and 500 patients affected with vaccine injury or COVID long haul. So I'd like to share that with you. Let's see how I do this. Most of this information comes from the Frontline COVID Critical Care Alliance website, which discusses an approach to managing post-vaccine syndrome and COVID long haul, last updated in January of this year. Let me start with a patient illustration, which is a 61-year-old white male with myocarditis and arrhythmia. He received a COVID vaccine about a year ago. He's a pharmaceutical rep, did not want to receive the vaccine, but was compelled to by the company with which he was employed. And within 2 to 3 weeks after receiving a Pfizer vaccine, he began to experience irregular heartbeat. The irregular heartbeat was so severe that he became short of breath and began to experience panic attacks, which he had never had before. His arrhythmia was so severe that he would have to get up from meetings with his employers in his pharmaceutical company and go outside just so he could breathe. He would be detailing his pharmaceutical product with doctors and medical offices, and he would experience the arrhythmia so bad he would have to excuse himself and go outside. Ended up having to see a cardiologist. He had stress tests. He had a heart cath. Cardiologist told him there's absolutely nothing wrong with you. That's been over a year ago, and he still has everyday irregular heartbeat almost every moment of the day. And he's driven to distraction by the irregular heartbeat, which started within 3 weeks of receiving that Pfizer vaccine. And he's not unusual. I have lots of patients who tell me similar stories. There's no official definition that exists for post-COVID vaccine syndrome. The CDC, the FDA, NIH, World Health Organization do not recognize post-COVID vaccine injuries as a specific medical condition. It's interesting because as soon as COVID entered the scene, there were definite diagnostic codes for COVID, for acute COVID. But although patients have been injured by the vaccine for over a year and a half, almost 2 years now, there's no definite diagnostic code or definition for post-vaccine injury or for COVID long haul. Nevertheless, as of 12/2/22, there have been over 1.5 million adverse events that have been reported to open VAERS. And as you've heard said already, open VAERS, the reports of that are 4 or 5 times more than actually are reported. There have been 36,000 deaths. Multiply that by 4 or 5. And to put that into perspective, when the swine flu vaccine was introduced many years ago, it was recalled within 90 days after 34 deaths. And yet, with this vaccine, there are more than 36,000 deaths reported to VAERS, and the vaccine is still being promoted by the CDC, by our government, and other agencies. 185,000 hospitalizations reported to VAERS, 15,000 heart attacks, 35,000 incidences of myocarditis, and 60,000 patients permanently disabled. Multiply those numbers by 4 or 5. The rate of serious adverse events is about 8% according to multiple surveys. The VSafe database, which interestingly has been removed, is 8%. A Polefish survey in July of last year, 8.64%. A Rasmussen report in December of last year reported serious adverse events at 7%. A U.S. veteran survey, 8.5% with the Pfizer vaccine, 7.9% with the Moderna vaccine. What's causing all this? It's the spike protein. Notably, the S1 subunit is likely the major pathogenic factor leading to the post-vaccine syndrome. There's an immediate reaction, which is a hypersensitivity reaction, which is not unique to the vaccine. All manner of medications and drugs can cause an immediate hypersensitivity reaction. So about 2.4% of folks receiving this vaccine can experience an immediate hypersensitivity reaction. What most people are concerned with is the acute myocarditis, or sudden cardiac death, that occurs within 24 to 48 hours. That's what you see in the media. These are the athletes that you see that receive the vaccine, and within 1 or 2 days, they're collapsing on the ball field or dying of a sudden cardiac event, usually an arrhythmia. In years past, about 25 college or professional athletes would die per year worldwide on the ball field. Since the rollout of these vaccines, the death rate is 25 per month worldwide, and that is shocking. And we're not seeing anything about that in the mainstream media or in medical journals. It's also due to a stress cardiomyopathy caused by excessive catecholamines, epinephrine, norepinephrine. There's a subacute or chronic myocarditis caused by the spike protein-induced inflammation. And that subacute chronic, it's weeks or months, maybe even years later, is a vaccine-related injury due to inflammation and autoantibodies, this activating the clotting cascade, or it may even cause viral reactivation. The inflammatory response is mediated by the spike protein. It induces monoclonal cell activation, and it primarily affects the brain, the heart, and the endocrine organs. What's the time course of sudden death? It's either that immediate, within 1 to 2 days to 14 days, and it is induced by catecholamine release and spike-induced inflammation in the heart. Or, and this really goes under the radar, 4 to 6 months later, after the last dose of the vaccine, there's no symptoms of post-vaccine syndrome in a lot of these patients, but then suddenly they experience sudden death. And it's usually caused by endothelialitis. That's inflammation of the lining of the blood vessels, and they're experiencing blood clots that leads to sudden death. The epidemic of sudden death, I want you to understand that the CDC data reveals that 84% of these, there was an 84% spike of excess mortality by the third quarter of the vaccine mandate. Pay close attention. Between March of 21 and February of 22, there were 61,000 millennials between the age of 25 and 44 age group that died excessively above the prior 5-year base trend line. 61,000 millennials in that 1-year span died above the previous 5-year baseline.
And Dr. Jackson.
Did you hear any of that in the media? Yes, sir.
And I think it would be hard to attribute that to COVID, seeing as how COVID does not typically kill that age group.
Exactly right.
Right.
And get this. This was after the Delta variant. This was the timing of the Omicron variant, which was much less virulent. More millennials died in 21 than American soldiers died in the 10 years of the Vietnam War. Some of you guys are my age, and you remember the outcry during the 10 years of the Vietnam War when 10,000 young Americans died during that war. But during that last 1 year, 61,000 young Americans, the same age as those soldiers who died in the Vietnam War, died after the rollout of the Pfizer and Moderna vaccines. Millennials started dying in large numbers at the same time when vaccines and boosters were rolled out and were made mandatory by academic institutions and employers and the government and the military. Also at the time when the less virulent Omicron variant was prevalent. Pay attention to the United Kingdom data. In 2020 and 2021, excess pediatric mortality was declining. Went down 9% in 2020, it went down 7% in 21, but then in 2022, the United Kingdom rolled out their vaccines for children, and the mortality went up 16% in 22, and it's projected in 2023 to go up by 22%. The correlation coefficient is 0.94, suggesting a very strong positive linear relationship between the COVID vaccine rollout and excess deaths. And that data comes from financetechnology.com. I'm going to skip some of this in the interest of time. First-line therapy for treating post-vaccine syndrome and COVID, by the way, is ivermectin, moderating physical activity, low-dose naltrexone, resveratrol, melatonin, 81 milligram aspirin. These are some of the treatments that I've used in my medical clinic. 80% of long-haul patients, 80% of patients who've had the vaccine experience some kind of long-haul symptoms, such as brain fog, cough, muscle pain, neuropathy in the lower extremities, and excessive fatigue. Let me give you two patient illustrations. One was a 50-year-old legal secretary. She was my girl Friday for a well-known lawyer in Spartanburg County. She came to see me and she was weeping, depressed. She had not worked a day for 10 months. She told me, Dr. Jackson, I don't even take a shower but once a week, and my husband makes me do that. I can't cook, I can't clean, I can't walk my dog. I haven't been to work in 10 months. She said, I've been to two doctors, both told me I just have to tough it out until I get better. But after she took the vaccine, it didn't help. She then got COVID, and all of these symptoms developed within a couple of weeks of developing COVID. And I told her, I said, ma'am, don't believe what you've been told. There is a treatment protocol. I put her on ivermectin, put her on melatonin. I gave her prednisone for 10 days, put her on resveratrol and quercetin. She came back to see me in a month, and she told me that in 2 weeks, she was back to her normal self, back to work. Her husband was shocked. Her employer was shocked. She said, all the brain fog is gone. And she said, Dr. Jackson, I'm back to my normal self. And she gave me a hug, and she danced me in a big circle in the exam room, and she's been fine ever since. I treated her for 3 months, tapered her off all the medicine, and I haven't seen her since. Second one is a 76-year-old grandmother. She had COVID. She got the vaccine, which did not help, and then she got COVID, and she was on oxygen, short of breath, coughing all the time, so fatigued that she couldn't drive her car. She hadn't been to church for 10 months, almost a year. Hadn't been to the pharmacy, hadn't been to the drugstore. She'd been going to see a pulmonologist in town who'd been giving her a cortisone inhaler plus the oxygen, and she was just not any better. When she came to see me, I said, ma'am, we can get you better. Put her on ivermectin and the rest of the medications and a budesonide nebulizer twice a day. When she saw me 2 months later, she told me, she said, Doc, within 2 weeks I was back to my normal self. I was off oxygen. I was driving my car, going to church. She went back to see the pulmonologist, who said to her, why are you taking this ivermectin? And she said, Doc, my family doctor put me on it, and within 2 weeks I was back to normal. And he talked to her a little bit more, and he said again, now why are you taking this ivermectin? She said, Doc, I don't know, you'll have to ask him, but I've been seeing you for 10 months, and you hadn't done a darn thing for me. And he put me on this, and in 2 weeks I was back to my normal self. So I'm here to tell you that there are treatments for COVID long haul and post-vaccine syndrome, but there are a lot of physicians out there that are not aware of proper or appropriate treatment. And there are patients out there that are getting well. Characteristics of COVID long haul: prolonged malaise, headaches, generalized fatigue, sleep difficulties, loss of taste and smell. My wife's one of those. 2 years later, after having COVID, she still doesn't smell food, still doesn't taste food, very frustrated by that. Painful joints, short of breath, chest pain, brain fog. And listen, I see 3 to 5 new patients every day who come to see me with post-vaccine syndrome or COVID long haul. Some of them drive from as far away as Wilmington, North Carolina, 6-hour drive, because they hear that there's a doctor that is willing and capable to treat them for these kind of symptoms. And I think that's enough of that. Let me conclude. The previous COVID variants and the current COVID variant has a minimal effect upon children, causing only a mild upper respiratory infection. The only deaths among children occur in those with a malignancy and an autoimmune illness. The vaccine does not prevent children from contracting the illness, nor does it prevent them from transmitting the illness to other family members. It's beyond me why we would take the chance of exposing children to the increased risk of excess mortality associated with the vaccine. Our government agencies have access to all the data that I've shared with you. They are charged with protecting our citizens, but don't seem to be raising any alarms about the vaccine. In fact, they're promoting the vaccine for our children. And as a family physician, that's what's concerning me the most, that government agencies are promoting the vaccine for children. If our government agencies do not advocate for the children of our state, then it's up to you as elected representatives to protect our citizens. We cannot afford to wait a year to collect our own statistics like the United Kingdom has just done. By then, the death rate among our children will have increased just like in the United Kingdom. And the responsibility will be laid at your feet and my feet as a family doctor. To be forewarned is to be forearmed. It has been said that silence in the face of evil is evil itself. Not to speak is to speak. Not to act is to act. And God will not hold us guiltless. In the Old Testament, it says that the men of Issachar understood the times and they took action. I know this is a listening session, but there's a time to listen and there's a time to take action. And all of us here are praying for you, gentlemen and ladies, that God will give you wisdom and sound judgment. I've got a lot of words, but I'm out of time.
Thank you, Dr. Jackson. Do we have any? Yes, Senator.
I just
Derek.
want to thank you. I got COVID and then took the ivermectin you told me to take. I didn't come to you, but I heard your testimony and I cleared up, and I never took one of those vaccinations, so thank you.
Thank you, sir. Thank you, sir.
Representative Long.
Thank you, Mr. Chairman. And yeah, I also got the ivermectin. Thank you very much.
Yes, sir. Yes, sir.
So, and you're the first physician we've had up here that actually kind of works in like a family medicine or any kind of medicine type practice. And I had a pediatrician tell me that basically they had to achieve certain vaccination rates among their patients.
They do.
Or they were going to be, I don't know if it was some kind of a financial incentive or disincentive to them that basically, and this was a pediatrician, so obviously there's a lot more child vaccinations. I didn't know if you were familiar, if that there was some sort of a way that the hospital systems track those sorts of things, what those incentives might be. Is it strictly the childhood vaccinations, or do they also do that for like flu vaccines? And have they, or would they do it for COVID as well?
All right. Physicians that are employed by hospital systems are incentivized financially to give pediatric vaccines. Pediatricians that are not are incentivized by their insurance reimbursements to reach a certain percentage in their pediatric populations by the insurers, by Blue Cross Blue Shield and others. to reach a certain percentage of vaccines. And I know that's for pediatric vaccines. Now, does that apply to the COVID vaccine, which is now being added to the childhood vaccine regimen? I don't know the answer to that yet, but it's a very good question. Okay.
Yes, Representative Davis.
Thank you. Thank you for being with us this afternoon and sticking with us for the other testimony. I had a couple of questions. Number one, why are doctors reluctant to treat with some of the medicines that you're using to treat long COVID?
It's a sticky question, okay? Most physicians, you call them frontline doctors, family doctors, internists, ER doctors are employed by hospital systems. Hospital systems in this state get their marching orders from the federal government. Federal government issued protocols in the beginning that said that certain medications were taboo, like ivermectin and hydroxychloroquine, and they promoted the vaccines. So doctors, like I'm employed by a hospital system, and so I received a little subtle note from my hospital that I should not be prescribing ivermectin. Now, I just told them they needed to stick to administration and I would stick to prescribing and treating patients. So that really didn't go anywhere. But there are others who listen to their hospital system. Now, hospital systems get 50% of their funding from the federal government. So when the federal government says no ivermectin, no hydroxychloroquine, then they listen and they put the squeeze on their physicians. And physicians, they have mortgages and children going to college and car payments. And so when the hospital says no ivermectin, they listen. You understand that pressure. At the same time, the FDA, who's not a physician, does not treat patients, was saying, hey, y'all, ivermectin is a horse paste. Y'all shouldn't be taking that. That's propaganda. You understand that. And a federal judge in Louisiana just last week said that the FDA overstepped its bounds. And the FDA is not a physician and should not be given advice like that, well, directives like that to physicians. They can advise, but they cannot command. And they overstep their authority in doing things like that. And so, in answer to your question, there were a lot of pressure on physicians. Now, the other thing is a lot of physicians are not what I call COVID literate in treating COVID long haul or post-vaccine syndrome. They're just not making themselves available of the information on how to treat it. Post-vaccine syndrome, COVID long haul is new. A lot of this stuff is new. And if doctors aren't availing themselves of the information, they just don't know how. And I have physicians calling me and asking, how are you treating these people? And what works and what doesn't work?
Do you know if the FDA has considered doing a series of studies on the effectiveness of those medications on long COVID?
There's been no prospective or randomized control studies on post-vaccine syndrome or COVID long haul.
Okay, thank you. And then also, the testimony that we heard earlier today about there being DNA in these vaccines, is that directly related to these incidences of long COVID?
Yes, ma'am, I'm convinced that it is.
Okay.
And now the spike protein, I think, is the main inflammatory agent. But I don't know what the DNA contaminant is doing to my patients. And that needs to be researched. And my advice to my patient is don't take the vaccine because I don't know what it's doing to my patients. And I'm alarmed by that. In fact, I'll be honest, in the very beginning, all of my medical career, I've always told my patients, do not take a new medication or vaccine until it's been on the market for a year. Because I've seen too many things pulled off the market within the first year. And so when this vaccine came out, my patients asked me, should I take it? And I said, absolutely not. Do not take it until it's been on the market for a year. And within the first 6 months, we started seeing the reports of serious adverse events. And I felt vindicated in telling my patients, don't take it. And so they kept coming back to me and saying, should I take it? And I kept saying, no, don't. And you see now the wisdom in that.
Okay, thank you.
Yes, ma'am.
I appreciate it.
Any
Anyone
other
else?
questions for Dr. Jackson? Dr. Jackson, I just had one. You seem to be way ahead of the curve with prescribing ivermectin, hydrochloroquine, the things that we all now know work. And I remember serving on Senator Martin's committee 2 years ago. I believe it was in September, 2 years ago. I mean, you were under a tremendous amount of pressure or heat from the hospital system. And basically, you turned around and told them what they could do with it. But has that come to an end? They're pretty well leaving you alone now.
The hospital system doesn't bother me, but I still cannot get a pharmacy to prescribe ivermectin, a chain pharmacy. I have to go through compounding pharmacies. And insurance companies will not pay for ivermectin. My patients have to pay cash for their ivermectin. It's over $140 for a month's supply. And, 3 to 5 patients a day are coming to me for COVID long-haul treatment, and they all have to pay cash for their ivermectin. And that's not fair. No. It's not right.
Ivermectin is used to treat other things other than COVID. I mean,
yes, we use it to treat parasitic infections.
Right.
We treat all manner of things.
Is that what's used to treat, say, if you drank bad water from a creek or something, you got Giardia or what's the other intestinal parasite that makes you really sick? Is ivermectin how you treat for that?
Not for Giardia.
Oh, yeah.
I mean, it might, but that's not what I would use for Giardia, no, sir.
Okay.
But it does treat all manner of other things.
I wonder, would the insurance company pay for it if it was used to treat other things?
Yes, yes. If the diagnosis is something else, they would pay for it.
But if the diagnosis is for COVID, they won't.
They will not.
That's interesting. Yeah. Okay. Thank you. Amy, any other question? Dr. Jackson, thank you so much for driving down and taking time out of your day. It's always a joy to hear from you. Thank you so much for presenting.
All right. Thank you kindly. The Lord bless you one and all.
Thank you. Amy, who's next?
Thank you, Mr. Chairman. Next up, we have Dr. Matt Clark, and I'm doing double duty, so I'm going to run full of presentation.
Dr. Clark, while you're coming, I just want to thank you for presenting. And can we ask questions along the way if need do, or you want us to wait till the end?
Yes, sir. I would just say that my answer is the same as the other fellow.
Okay.
As long as the time restraints are a little bit looser, because I got a lot to say. I probably put too much in my presentation.
Okay.